Welcome to this deep dive. Today our mission is to break down a really comprehensive A to Z patient guide. We are talking all about osteoporosis.
Yes, and I have to say, it is such an important topic.
It really is. So we're going to unpack this medical text to give you, the listener, a completely practical, working understanding of what osteoporosis actually is, who really gets it, how we detect it, and exactly what you can do to protect your skeleton.
Because basically there is a lot of misinformation out there.
Oh, absolutely.
Okay.
But before we get into the solutions, we need to talk about the problem. And the hook here, which is frankly a bit scary, is that this disease dismantles the one thing we all rely on, which is our body's alarm system.
Right. The warning signs.
Exactly.
Yeah.
Usually when something goes wrong in the body, a bell rings, you get a chest infection, you run a fever, you pull a muscle, it swells up and hurts. But what the surgeon's notes make terrifyingly clear is that osteoporosis does not announce itself.
No, not at all. It's completely silent.
Right. There is no dull ache. There is no joint pain. You could be walking around today, right now, with bones that are actively hollowing out from the inside, and you would feel absolutely nothing.
See, that is actually the most dangerous aspect of clinical practice when dealing with this. Patients walk into the clinic expecting that if a major structural column of their body was failing, they would surely feel a tremor, right?
You would think so.
But the loss of bone density itself is completely painless. Osteoporosis literally means porous bone. It develops very slowly over decades. So by the time a patient actually feels pain, it is not from the disease itself.
Wait, so where does the pain come from then?
The pain only arrives when the weakened bone finally gives way and snaps.
Wow. Okay, I want to stop right there, because to understand why there are no early warning bells, we kind of have to unlearn how we think about the skeleton.
Definitely.
Because I think most of us imagine our bones as this static, lifeless scaffolding. We think of it like the steel beams holding up an apartment building. Once it's built in your 20s, it just sits there doing its job.
It's a very common misunderstanding, actually. Let's be practical for a minute. Your bone is not concrete. It is highly active, living, breathing tissue.
Okay.
It is constantly undergoing a process called remodeling. Right now, as you are listening to this, microscopic cells in your body are actively dissolving old bone, and other cells are laying down fresh new bone.
Let's give those cells their proper names, because it helps visualize the mechanics. I think the guy talks about a demolition crew and the builders.
Correct, yes. The demolition cells are called osteoclasts. They secrete these enzymes and acids that dissolve the old microscopic layers of bone tissue.
Like tiny bulldozers.
Exactly like that. Then, the builder cells, the osteoblasts, they come in and fill those microscopic craters with new calcium and protein.
Yeah.
Every single day of your life, this cycle is happening.
Which is amazing.
I mean, in fact, you get a completely new skeleton roughly every 10 years.
Wait, really? A whole new skeleton?
Basically, yes, it's constantly renewing.
Which makes sense when we are growing, right? I mean, in your teenage years and 20s, those osteoblasts, the builders, are working double shifts. You are depositing way more bone than you are losing, building up your peak bone mass.
Yes, that's the ideal scenario.
But if this is a natural cycle, why does osteoporosis happen? Do the builders just get lazy?
Well, it is more a case of the demolition crew getting overly aggressive.
Ah.
When you hit your late 30s and early 40s, the balance subtly shifts. The osteoclasts start removing slightly more bone than the osteoblasts can replace.
So the craters don't get fully filled in.
Exactly. Over time, the internal architecture of the bone, which, by the way, looks a bit like a honeycomb, starts to lose its density. The walls of that honeycomb get thinner and thinner until large holes appear.
And because this remodeling happens on a microscopic level deep inside the tissue, there are no nerve endings firing off to warn you.
Right. The building is literally being hollowed out from the inside, quietly.
But because you can't feel it, we have to figure out who is at risk. I mean, we can't rely on symptoms. We have to rely on identifying the people whose biological demolition crews have gone into overdrive.
And this is where we really have to look closely at the medical risk factors, starting with hormones. See, the most common demographic we see in the clinic is postmenopausal women.
And people just accept that as a fact of life. But let's explain the why for our listeners. What does menopause have to do with bone cells?
It all comes down to estrogen. Estrogen is incredibly protective of the skeleton.
How so?
Well, its primary job in bone health is to keep those osteoclasts, the demolition cells, in check. It literally limits their lifespan. But when a woman goes through menopause, estrogen levels drop off a cliff.
Oh, I see.
Yes. So without estrogen acting as the supervisor, the osteoclasts live longer and work much harder. the rate of bone loss speeds up dramatically.
Okay, but this brings us to a major stereotype that needs breaking.
Let's break it.
Because I hear osteoporosis and my brain immediately pictures a frail, 75-year-old grandmother. But the surgeon's guide heavily emphasizes that men get it too.
Oh, absolutely they do.
But if men don't go through menopause and don't rely on estrogen in the same way, what triggers the hollowing out of their bones?
Testosterone.
Oh, really?
Yes. In men, testosterone performs a very similar protective function for the bones. As men age, their testosterone levels decline. Not as abruptly as estrogen during menopause, but steadily.
Right.
If a man has unusually low testosterone, or if he's a heavy smoker and drinker, his bone density will plummet. We see older men in the clinic with severe hip fractures all the time.
And I bet they are shocked.
Oh, completely. They are always shocked to hear the word osteoporosis applied to them.
Wait, I'm going to push back on this timeline entirely because a lot of younger listeners might be tuning out right now thinking, well, I'm 35, my hormones are fine, I'll worry about this in 30 years.
They shouldn't tune out.
Exactly, because the notes clearly list significant risks for younger adults as well.
Osteoporosis absolutely affects younger adults. We call this secondary osteoporosis.
Meaning it's secondary to something else.
Correct. It means the bone loss isn't caused by natural aging, but by another medical condition or medication that is sabotaging that bone remodeling process we talked about.
The guide specifically mentions coeliac disease. Let's trace the logic there, because coeliac is an autoimmune reaction to gluten that damages the gut. How does a gut issue dissolve your spine?
It is a brilliant example of how interconnected the body really is. See, if you have undiagnosed coeliac disease, your gut cannot properly absorb nutrients from your food, specifically calcium and vitamin D.
Okay, that makes sense.
No, your body needs calcium in the blood to keep your heart beating and your nerves firing. That's a priority.
Right.
If it isn't getting calcium from your diet, the brain kind of panics. It releases a hormone that sends a massive signal to the osteoclast saying, go dissolve the bones immediately. We need that calcium in the bloodstream right now.
That is wild.
Yes. So your body literally sacrifices your skeleton to keep your heart running.
The skeleton is basically a calcium bank, and the body is making massive, unauthorized withdrawals.
That is exactly the right way to think about it. And medications can force these withdrawals too. The most notorious culprits are corticosteroids.
Like steroids prescribed for severe asthma or rheumatoid arthritis.
Yes. Or other inflammatory conditions.
Which a lot of people take daily. Are you saying an asthma inhaler is dissolving my bones?
Let's clarify the dosage there. An occasional inhaler isn't the primary concern.
Okay.
We are talking about long-term, high-dose oral steroids. Glucocorticoids are highly effective at stopping inflammation, but they have a severe side effect.
Yeah.
They actively kill off the osteoblasts, the builder cells.
Oh, no.
Yes, so the demolition continues, but the rebuilding completely stops. A 30-year-old on long-term steroid therapy can easily have the fragile skeleton of an 80-year-old.
And when you layer on modern lifestyle factors, smoking, sitting at a desk for 10 hours a day, poor nutrition, you are basically handing the demolition crew a blank check.
A blank check, exactly.
Which brings us to the tipping point. The disease is silent for years, decades even, until the structural integrity gets so weak that it fails. The surgeon refers to this as a fragility fracture.
Yes. The fragility fracture is the watershed moment. It is the defining clinical event.
So it's crucial.
Very. If you want to understand osteoporosis, you must understand this term.
By definition in the guide, a fragility fracture is a bone break resulting from a minor bump, a low-energy fall from standing height, or a seemingly harmless daily activity.
Right.
We are not talking about falling off a roof or getting tackled in a rugby match.
Not at all. We are talking about slipping on a wet bathroom tile, tripping over a charging cable in the living room.
Things that happen every day.
Exactly. For someone with healthy bones, that impact causes a bruise. For someone with severe osteoporosis, that same impact shatters the wrist or the hip. The mechanical force simply does not match the level of destruction.
It's like getting into a 3-mile-per-hour fender bender in the grocery store parking lot and the entire engine block falls out of your car.
That's a great way to picture it.
Because the chassis was already rusted through.
Exactly.
And the guide notes 3 classic sites for these breaks: the wrist, the hip, and the spine. The wrist makes sense. You fall, you put your hand out. But the spine fractures, those sound terrifying because of how they happen.
Spine fractures often happen without a fall at all.
Really?
Yes. Remember the honeycomb structure we talked about? The vertebrae in your spine are carrying the entire weight of your upper body. When those bones become hollowed out, everyday mechanical pressure can be enough to break them.
What kind of pressure?
Like bending over to lift a heavy bag of groceries or even coughing violently, it can cause the front part of the vertebral bone to simply crush under the weight.
Oh, wow. The notes call them wedge fractures.
Yes, because the bone collapses into a wedge shape. And here's the tragedy of it, honestly. Many patients don't even realize they've fractured their spine.
How could you not know?
Well, they feel a sudden sharp backache, and they assume they just pulled a muscle. But as these microscopic collapses happen across multiple vertebrae, the spine starts to curve forward.
Oh, I see.
That stooped, hunched posture you often see in the elderly, that isn't just old age. Those are healed, undiagnosed spinal fractures.
And they're literally losing inches of height in the process.
Yes.
Unfortunately.
But the biggest warning the surgeon gives in this entire guide is about the cascade effect. One fragility fracture massively increases the risk of a second one.
This is where we face a huge communication gap in clinics. I'll tell you what happens. A patient comes in with a broken wrist from tripping on a rug.
Right.
The wrist gets put in a cast, it heals, and they go home thinking, well, I'm just a bit clumsy.
Hey, brush it off.
Exactly. They miss the message entirely.
Yeah.
That broken wrist was the fire alarm finally going off. It is screaming that the systemic bone density is critically low.
So it's not just an isolated incident. No. If we ignore that wrist fracture, statistically, the next fall will be a broken hip. And a broken hip in an older adult is a life-threatening, devastating injury that permanently strips away independence.
Which makes detection before the hip fracture absolutely vital.
Absolutely.
So let's pivot to diagnosis. How do we actually see what's happening under the hood before the engine falls out?
Diagnosis requires looking at both the patient's history and their internal imaging. First is clinical suspicion like, has the patient lost height? Are they on steroids? Do they have a family history?
Right.
Then we move to the gold standard of imaging, the DEXA scan.
Right. Dual energy X-ray absorptiometry. Essentially a specialized, very low-dose X-ray. You lie on a table for 10 minutes, it's painless, and the machine measures the actual mineral density of the bones in your hip and lower spine.
Correct.
But I want to make sure you clarify something here. The scan gives you a T-score, which compares your bone density to a healthy 30-year-old. It's very easy for a patient to look at that piece of paper, see a bad grade, and panic.
It happens every day, actually. But a DEXA scan does not replace a doctor's clinical judgment. We treat the patient, not the piece of paper.
I love that.
The T-score is just one data point. See, if a patient comes in with a borderline DEXA score, but they have already suffered 2 fragility fractures from minor falls, they have osteoporosis.
The proof is in the pudding.
Exactly. The disease has already proven itself in the real world, regardless of what the machine's algorithm says.
You're also running blood tests, right, to look for those underlying causes we mentioned earlier, like severe vitamin D deficiency or thyroid issues.
Always. Because if the bone loss is being driven by an overactive parathyroid gland, giving them standard osteoporosis medication won't solve the root problem. We have to find the why before we decide on the what.
And that leads directly to the treatment phase.
Yeah.
Let's be honest, this is where patients start to get very hesitant.
Oh, very much so.
The surgeon's guide outlines lifestyle changes, which everyone loves, and medications, which everyone fears. The primary goal of any treatment plan is fracture prevention. Stop the next break. But the medications mentioned, like bisphosphonates, have a reputation online that scares people away.
WhatsApp University has done a lot of damage here.
Tell me about it.
People read about incredibly rare side effects online and they just refuse the medication. Let's explain how these drugs actually work because it really demystifies them.
Okay, let's hear it.
Bisphosphonates, which are the most common first-line treatment, work by specifically targeting the demolition crew.
The osteoclasts.
Exactly. The drug binds to the surface of your bones. When the osteoclasts come along to dissolve the bone, they ingest the medication, which effectively disables them or causes them to die off early.
Oh, wow.
So by stopping the demolition, you allow the builders, the osteoblasts, to catch up and fill in the craters, naturally increasing bone density.
Okay, but let's address the fear. People read that these drugs can cause jaw issues or weird femur fractures. If I'm a patient sitting in your clinic feeling perfectly healthy, why would I risk taking a drug that might cause a rear bone issue?
Because we have to weigh statistical reality against perceived fear. The side effects you mentioned, like osteonecrosis of the jaw, are exceptionally rare.
How rare?
Very rare, mostly seen in patients taking massive intravenous doses for cancer, not the standard oral doses for osteoporosis. Now, contrast that incredibly rare risk with the very real immediate risk of a hip fracture.
Right.
Do you know the mortality rate for an older adult who breaks their hip? A significant percentage do not survive the following year due to complications from being bedridden, like pneumonia or blood clots.
That puts in a very stark perspective. The
Hmm.
surgeon actually has a powerful quote in the guide. He writes, um, the right question is not, are these drugs perfect, but are they worth it for my risk?
That's exactly it.
If your risk of a life-ending hip fracture is 30% in the next 10 years, a fraction of a percent risk of a medication side effect is a trade-off you absolutely need to consider.
Precisely. And a good doctor will continuously monitor you, giving you drug holidays where you stop the medication for a few years to minimize any long-term risks. But medication is only half the prescription.
Right, because if you're not fixing the foundation, the drugs will fail.
Yes.
This is where we get to the foundational defense. Diet, exercise, and environment. We've mentioned calcium is the building block. But you can't just drink milk and expect it to magically become bone, can you?
Not without vitamin D. Think of vitamin D as the key that unlocks the door of your intestines, allowing the calcium from your food to enter your bloodstream.
Okay, I like that analogy.
Most of us live in air-conditioned offices and avoid the sun, so our vitamin D levels are really abysmal. If you are deficient, you need medical-grade supplements, otherwise all that dietary calcium just passes right through you.
And then there's exercise. The guide doesn't just say be active. It is very specific. Weight-bearing activity and resistance training. Why doesn't swimming or cycling help osteoporosis? They are great for the heart.
They are fantastic for cardiovascular health, yes, but terrible for bone density.
Why is that?
This comes down to a biological principle called Wolff's Law. Bone grows and remodels in response to the mechanical stress placed upon it.
Okay.
So when you lift weights, walk briskly, or climb stairs, gravity and muscle contractions are bending and stressing the bones slightly. The osteoblasts sense this stress and say, we need to make this area stronger to handle this load.
Ah, I get it.
But if you are floating in a swimming pool, there is zero mechanical stress. The bones get no signal to grow.
Okay, but this brings me to the most surprising insight from the entire clinical guide. We've talked about osteoclasts, estrogen, bisphosphonates, Wolff's Law, all this complex biology.
Yes.
But the surgeon argues that one of the absolute best medical interventions for osteoporosis doesn't involve the body at all. It involves your living room.
Fall prevention. It sounds overly simple, but it is the ultimate pragmatic medicine.
It makes complete logical sense when you think about it. A fragile bone doesn't just spontaneously explode, it breaks because it hits the ground. If
Exactly.
you don't fall, you don't fracture. So treating the disease means treating your environment.
We spend hours explaining bone density scores to patients, but the most life-saving advice I can give is fix the lighting in your hallway so you don't trip when walking to the bathroom at 2 a.m.
It's so practical.
Tape down those loose decorative rugs. Get rid of the slippery bathroom mats. Wear proper supportive footwear indoors instead of loose slippers.
It is incredible to think that upgrading a light bulb and throwing away a tripping hazard is a literal first-line medical defense against a silent degenerative disease.
It is the perfect marriage of biology and environment. You take the medication to strengthen the internal architecture, and you modify your house to ensure you never test that architecture's breaking point.
To summarize this journey for everyone listening, osteoporosis is a silent hollowing out of your internal scaffolding. It doesn't hurt until it breaks. It is driven by aging, hormone drops, gut issues, and certain medications.
Very true.
But you don't have to wait for the alarm bell of a shattered wrist. You can get assessed,